If we go to you, Alice, is that okay?
Yeah, thank you, Michael. Thanks, Barry. I'll just share my screen now. Okay, so you should all be able to see the beginning of the presentation. So, yes, I'm Alice, a healthcare lead. I'm an architect and also an interior designer based here in West Yorkshire at P+Hs Architects. I've specialised in healthcare design for about 13 years now, and I have a passion for improving healthcare environments and researching best practice both from the UK and abroad. And thank you for the opportunity on behalf of Architects for Health to be on the panel today. This is a really great subject, and that as advocates for best practice in healthcare design, Architects for Health are really passionate about. So today we're talking about the infrastructure that surrounds the future of healthcare in West Yorkshire. We'll be exploring trends from the UK and abroad and how investing in infrastructure can transform lives. Infrastructure is a very broad topic, so I'll be talking about a few key points that will cover aspects of what makes a healthy environment, what we can aspire to in the future, and a few case studies of how this is being achieved both from the UK and abroad. We know that the healthcare system in isolation is struggling. There's an estimated £9 billion worth of backlog maintenance, not to mention that 1.5 billion and rising is a health risk to the life of patients and staff and needs to be addressed. Hospital sites generally need upgrading nationally, but what other areas of infrastructure leading up to hospital admissions do we need to improve across the region to improve the health and well-being for all generations? And how can we improve our social care system and regenerate deprived areas? So many of our health issues that we see today are actually preventable or can be improved through careful understanding of the local community's needs and bridging inequality gaps through improving our local infrastructure. Thoughtful design and creating healthy, high-quality places that are well connected and supported should be the foundation that strengthens community, creating opportunities to socialise and encourage positive activity. So the wheel that's shown here is taken from the World Health Organization's vision for healthy cities. You may be aware of this movement already. I've just placed it here along with the key checklist, just as a reminder for what attributes are globally recognised to create healthy cities. And, just to summarise quickly, these cities lead by example in order to achieve change for the better. And the aim is to tackle inequalities and promote good governance and leadership for health and well-being. And most importantly, what's really great about this is their vision starts with people. And a healthy city takes a human approach to development. It prioritises investment in people, ensuring access for all to common goods and services. So there's more information on their website about this initiative and how to take part. So whilst we're focusing on people as a starting point, I'm just going to dive straight into specifically the NHS workforce and the current built environment within which they work, just to emphasise really how important this is for infrastructure in the future of healthcare. The workforce and the individuals who provide care are very much affected by the healthcare environment on a day-to-day basis. I'm just going to read out a couple of key facts quickly from the King's Fund website that carried out some research into staff welfare. So even before the pandemic, the workforce crisis was the biggest challenge facing the health and care system. NHS hospitals, mental health services and community providers were operating with more than 100,000 full-time vacancies. Staff were working under strain, with 40% of respondents to the survey reporting that they felt unwell due to work-related stress in the last year. And a majority, so that's 51%, over half, are thinking about leaving their current role, and 21% want to quit the NHS altogether. So it's really, really clear that improved staff environments are key to creating a sustainable workforce. And in upgrading our hospitals and healthcare premises, it is important that we create adequate breakout spaces and rest areas, rooms for private one-to-one conversations, changing the brief a little bit on what we're providing for them at the moment as a minimum. Their health and well-being is really important so that they can deliver the best care possible. Hospitals of the future should become a place of choice to work due to the amenities and the culture of the workplace. P+Hs asked staff at an existing trust here in West Yorkshire what they would like to see for their staff areas in the new building, and they referred us to companies such as Google and Patagonia due to their working culture. And as architects, we can only do so much. The culture and the operational principles for staff welfare also need including as part of any upgrades. Let's click on to the next slide. And every development, from the big to the small, that gets built today and in the future, should, where possible, incorporate a wider picture that is the health of the local community. Evolving the culture of our built environment through embedding healthy living within our policy frameworks will help us to drive towards this vision. Developers need to be motivated to provide healthy spaces of their own accord. If responsibilities for achieving these aspirations are clearly defined, designers and developers can work harmoniously together in creating sustainable and healthy communities. And there are many opportunities to build communities where people want to engage with one another, to encourage, to motivate individuals to take ownership of their own health needs. So what can be done in the future to prevent loneliness in older adults, or, create spaces that encourage social interaction? How can we destigmatize mental health services or even make sexual health clinics easily available? So an example of how this cultural shift is happening here in Leeds is where we've adopted a Scandinavian urban principle to improve the overall quality of life for residents. So the Situ development, which is located centrally in a former brownfield site, is the master plan for the new climate innovation district. It's been developed with Scandinavian firm White's architecture to convert the space into a sustainable mixed-use neighbourhood of more than 500 apartments and homes. So it's quite a lot of it's complete now, actually. The development has got a really high standard of environmental performance. It's got fully integrated services that are well connected. It's got schools, commercial offices, manufacturing, as well as healthcare. And the resilient development has wide access to a range of social and green space to encourage social interaction, physical activity and play with non-vehicular movement, as the design is, it's more pedestrian and cycle friendly. So the Situ development is a start. It's just a section of one city in West Yorkshire. So what more can be done in the future to connect other parts of our cities and their wider suburbs? A great example from the US is a Highline Park. It's a new artery of green space that connects several areas of New York City. It's a really clever use of an old elevated railway track, which now takes pedestrians off the street of New York into nature. I've been there myself. There's little bird boxes and reclining seats and amphitheatres which form part of the public realm. And, it's a really attractive, joyful space. It's, and it takes you on a journey through some amazing architecture as well. It really stitches the city together. And Leeds has some great ambitious plans for a further 100 kilometres of cycle routes. This will mean a lot of clean air and a greater connection with nature, and it'll be a big boost for physical and mental well-being for residents. And, across the way, our neighbours in Manchester, they're building the B network, which is a really great emblem of nature and is now connecting loads of different communities with cycle lanes and walking routes around Greater Manchester and the city itself. So again, we can look to Scandinavia for best practice for many aspects of healthy living. One of these aspects is how they value multi-generational living. So there's an image to the bottom left there. It's from a concept image for Generations House, which is actually now built and operational, and you can look at it online. There's some as-built pictures. It's really beautiful. It's located in Aarhus and it's based on life and community. It'll be the first of its kind in Denmark and has been tested on smaller scales. It delivers on Aarhus's district's vision of bringing together several generations under the same roof. 40 of the units are designated youth homes, 100 are for the elderly and 24 are reserved for adults with different disabilities. And in addition, the building will contain 40 family homes, a number of common areas, including a nursery for 150 children. So here, children, young people, adults and the elderly will all be able to coexist. The layout's been designed in such a way to create opportunities for residents to meet by sharing resources and taking part in communal activities. The building houses function rooms as harbour setting with sailing boats and kayaks, workshops, children's playgrounds, etc. There's even a mini zoo. And the need for providing additional care homes was identified and, by the local council and therefore included within the city's master plan. But the city was really intent on providing care dwellings mixed with other programmes, as care for the elderly in Denmark generally is heavily based at home. It meant that residents here that needed extra care had more significant care needs, with a higher proportion of individuals that had dementia. And in order to make the new development work, the local authority had to collaborate with the Ministry for Children and Youth, the Ministry for Health and Care, the Ministry for Social Relations and Occupations, and housing associations. And in the north, we're starting to develop schemes of a similar sentiment, which will enable children and the elderly to be more connected. And this will have many benefits, such as freeing up time to care within the community and stimulating minds and creativity and preventing dementia. So the image to the top left there is another example from Denmark. It's the proposed House of Food and Culture, which is located strategically in a prominent location in Frederiksberg, Arla, Copenhagen. It's built on top of a proposed metro station. So it's very well connected and it's intended to be the capital's new meeting point with a daily footfall of up to 10,000 people. And the first 2 floors will house culinary experiences, workshops, educational facilities. So here in West Yorkshire, on a much smaller scale in Seacroft, we have a new community kitchen. But maybe in the future, perhaps we could build on this, make it more of a prominent community amenity on the high streets in West Yorkshire to educate about nutrition. So I'll now just move on to talk about variations of accessible health facilities. So in the north, we P+Hs have delivered the first and actually currently still only BREEAM outstanding health hub in Horton, which is the picture to the bottom left. And the development combines medical care, wellness within a sustainable development close to where people live. Traditional healthcare services are provided alongside services previously accessed through hospitals, including X-ray, minor surgery, and a 24-bed rehabilitation unit. It's located adjacent to an existing leisure centre, and the new facility is a landmark for community healthcare. And externally, the site offers wide-ranging exercise options. It's got skateboarding, a trim trail, games pitches, etc. And we're also currently involved in early stages developing integrated health hubs here in West Yorkshire at the moment. It's a bit too soon to go into them in detail. But we have been working with local CCGs and helping GPs to work collaboratively to join together in creating more streamlined, flexible and accessible care services. They're located close to transport links. So one of them is a new health hub proposed for Castleford and plans to be centred and integrated as part of the community strategic master plan with improved transport and upgraded pedestrian links. The image to the top left there is of the new Maggie Centre at Leeds St James's Hospital, which we're really fortunate to have one of these. It's a welcoming, well-crafted space with a high-quality finish, and it welcomes any member of the public affected by cancer. It demonstrates a quality and budget that really make the difference in creating a sustainable community and effective healing environment. it is an example here on how we're relying on charities really to bridge the gap in creating uncompromised quality. The detailing and creativity is really inspiring. It's surrounded by greenery, it's got double height spaces, it's purely a therapeutic space, and the importance of which, is really acknowledged for supporting survivorship. Improving the quality of our care environments within our community is, key to achieving long-term value. So I suppose, another question is, could we think a bit more flexibly about some of these spaces? Could we open them up out of hours and share some of these spaces if we need to think a bit differently about budgets? So just moving on to acute care, there's probably not a super hospital solution to the general future health of West Yorkshire, but regenerating our hospitals and building new hospitals will form part of this. Providing more specialised network of hospitals is probably more likely, that are intelligent and smart, that integrate digital state-of-the-art technology and allow for fluctuations in demand for beds. So building the need for now and the future is a challenge, especially with the constant advancement of medicine. It's sometimes hard to predict the future, but we will always have a need for inpatient accommodation and acute facilities. But the frequency and the duration of our stay may change. The provision of single beds are becoming the standard in the Nordics and other areas of Europe, and there's evidence-based design that demonstrates patients heal faster, have less disruption. Although again, it comes down to whether or not this is an appropriate way to manage the wards. But now, with things such as COVID, it might be something we may think about differently as well in the future. So an example of how this is managed is through a case study here, which there are images from, which is a hospital in Basel, which I visited a couple of years ago. It had just been built. It's in Switzerland. It's 280 beds, including a private ward. It's called P+Hs, and it's the largest centre for geriatric medicine and rehabilitation. It's also a university hospital. It combines expertise in acute geriatrics, geriatric psychiatry, and rehabilitation, all in one facility. The wards are arranged in pairs, and they work together for flexibility. You can see a bedroom on the bottom left there with a thin line sort of in the ceiling. So the bedrooms are designed to house two beds, but they're generally provided as a single room. So when there is a need for flexibility or patients can be paired, they are. I know with geriatric care, sometimes it's better to have two people in a room to help with observation rather than having single rooms. There's also a mobile digital trolley which identifies on each ward when there's a hive of activity in the adjacent ward, so that staff can move across and provide extra support and flexibility. So another example is an increased use of patient hotels. There's one recently been built in Copenhagen, which is really beautifully designed. We refer to this sometimes as step-down care, and this is part of the hospital infrastructure, but for less acute illnesses on patient journeys home. So you may see more of this too, which will free up care within acute hospitals, within acute areas of the hospital. And we will also see a lot more personalisation of healthcare, people taking more responsibility for prevention. We'll probably have a lot more apps, getting to know individuals' needs. And also when we're designing, a key element of success is really designing from the perspective of the service user. So this is something that Scandinavia do really well by focusing on the actual outcomes. And we need to stay genuinely focused on society, health and well-being by looking towards people as the inspiration. Okay. So thank you all for listening. If Architects for Health can help anyone here today. Please get in touch. And there's some contact details on the slide here. And there's also some further reading notes there. And yeah, thank you very much. That's all. Sorry if I went over. I added a few things at the last minute.
No problem, Alice. No problem at all. Thank you so much for a fascinating talk, showing us how caring design can improve lives and touching on a theme which I've sort of thought about but not really done anything about, which is that if staff feel valued through the environment that's provided for them, they're much more likely to work better, to stay in work, and to be able to get over periods of demoralization. And that goes for all of us in terms of the environment we live in. So I think you've highlighted that very excellently for us, and we're most grateful. Perhaps we can move on to our second speaker this afternoon, Richard Topping. Richard Topping is the Senior Director of Global Business Management at Draeger Medical Systems in Massachusetts, USA. He originally trained as a nurse. He was actually born in Huddersfield. He's worked across many countries in Europe, Asia, and America for Draeger. He's passionate about using technology to improve patient care, and I'm very much looking forward to what he has to say. Richard, the floor or the airwaves are yours.
Thank you very much. Just as my aircon just comes on to blast, so I hope you can all hear me over the noise of the aircon. It should switch off very shortly. Thank you for letting me speak today. And I was given a very, very broad topic, that of innovation in healthcare. So that was very interesting, deciding where to actually start with that. But before I start, Barry mentioned at the beginning that this webinar was, going to go across the party benches, that it wasn't political in any way. And I want to follow in that same theme by making a disclosure here that obviously I work for a medical device company who provide, ventilators and anesthesia machines. But my invitation here was really to bring across to you my experience, from working around the world, the things that I've seen, what I consider to be best practice, and to bring those through to you today. So in that, I'm taking a very impartial view. So some of the topics that I'm going to cover, touch with what my company do as business, but there are also other areas which are outside of the scope of our business, and which make up a bigger picture. And so with that, I've tried to be neutral with some of the pictures and images that I use, but some of them are obviously from Draeger, my company, but others do actually include solutions from other providers and even some of my competitors that I've put in there as well. So some of the hospitals that I've referenced as well that I'm going to tell you about, they're usually ones that I've been directly involved with, ones that I've visited, but also ones which I've worked with indirectly, some of them as customers and some of them not. So as you probably just heard, I'm originally from Huddersfield, as I'm a Yorkshireman, but I've travelled quite extensively, lived abroad in Singapore, Germany, the Netherlands, now here in the United States, but my, origin was from Huddersfield, born in Huddersfield Royal Infirmary, worked as a staff nurse on the intensive care unit in Hull. And you can see on the map there the number of countries that I've visited across the globe for work. It's currently up to 89 countries. But what I've been able to glean from that is that the world is far from homogenous. It's very, very different. There are lots of different aspects to healthcare pertaining to culture, pertaining to the resources, pertaining to the governmental and healthcare infrastructures. But what we do share very often is some of the same goals. So this one that you see here on the right-hand side is called the quadruple aim. And it's really come from the United States, but it's actually something that I think is very applicable throughout the world, including to the United Kingdom. So what we're looking at here is obviously looking at the best outcomes for patients, driving that forwards. But we are also doing that under very, very stringent, cost requirements, especially here in the United States, where the cost of healthcare is outstripping, anything else in terms of earnings and GDP. And so everyone is trying to sort of look at how we do the best for patients and to get the best from the available resources. And of course, from that, we want to, give patients the best experience as well. But something that Alice touched on in her presentation, which resonates with me, is the well-being of the care team. So the staff satisfaction, because staff are now upwardly mobile. They can, go on and to get other jobs. You heard again what Alice said about the number of nurses and healthcare workers who are considering leaving the profession, but others, go abroad as well. There's a big proportion of British nurses who or doctors who are currently residing in Australia, and some of my friends are among them. So when we heard the first presentation from what Alice was saying, and in some discussions we had before this webinar actually started, looking across the care continuum, you've heard, some of the tactics that we could have to actually try and promote a healthy living, to try and prevent disease, so the use of primary healthcare. But we can't get away from the fact that at some point, we're going to have patients, and we're going to have them inside hospitals. So today, my presentation is really going to focus on the services and some of the innovation that you find in those acute hospitals. Here, looking at how patients come into hospital, usually through something like the emergency department, the accident emergency, and then going across their journey within the hospital, their treatment, and then going obviously back out into the community again. And you heard again Alice's perspective on what she saw in Scandinavia with the use of the hotel as a kind of step down facility. And so this brings us to a question about the role of the hospital within the community. And certainly, while it plays a very prominent role, the trend is probably going to be in the future to try and keep people at home through doing things like remote monitoring, and try and keep them there rather than coming into the hospital. And in places like the United States, there are certain ways that the insurance companies try and incentivize healthcare providers to try and do exactly that. But this is a quote I quite liked, because sometimes we can get very rigid ideas about, the building, about hospitals. But Leland Kaiser, so from Kaiser Permanente, he said, the hospital is a human intervention and as such can be reinvented at any time. So what I'm going to talk to you about is basically what I've been seeing from around the world, both in terms of the building, what the designs of hospital layouts that I've seen, the trends that are there, but also then I'm going to focus in a little bit about the technology and areas of innovation that surround that as well. So of course, when you're thinking about hospitals of the future, even today, you have all these wonderful and pretty wild, concepts. And it will be interesting to see where we go in the future. As I just mentioned, will the hospital expand with the number of elderly patients and the number of chronic diseases, which certainly the Western countries are going to have to address in the future? Or will there be less beds? So exactly as Alice just mentioned again, that there's a shift to home care for those less seriously ill patients. What we do know is that the patients in hospital, and particularly in the acute areas such as intensive care units, will probably have more and more complex pathologies. And this will be aided, by precision medicine. And again, it was something that Alice mentioned in her presentation about tailoring therapies, really personalizing healthcare based on the individual characteristics, on genetic markers, on the risk profiles, and those, concepts as well. So here you can see a picture of, very nice hospital room. If they all look like that, that would be fantastic. And at the top, this is a concept bed for an intensive care bed for the future, where rather than having a monitoring device displaying on the wall, this is now projected sort of as an integrated part of the actual bed itself. So maybe we see that at some point in the future. But maybe the future isn't as far away as you would think. So this is something which a number of hospitals have used. You've seen them a little bit in Japan. But Tommy, the robot nurse here, was actually used in the pandemic in Italy. So really at the epicenter of the COVID-19 battle. And they actually had 6 robotic nurses, which are, about the size of a child. And they stay in the room and actually monitor the parameters from the various equipment and send that information to the clinicians. But rather than just, relay that information, they have a screen which can allow patients to record messages and send those to doctors. So, what is the benefit of this? You could argue that it's rather impersonal having such devices, when you could have human-to-human contact. But of course, we're in this situation where, hospital staff are at a premium, where staffing levels are challenged. So here, especially in the COVID situation, where, there were a lot of patients coming into the hospital where staffing ratios were under pressure, this could free up, clinical staff to focus on those more critically ill patients. And of course, it also protects again for clinical staff as well, because, they may not have to go into the rooms quite so frequently to gown up, to put on their personal protective equipment, to go in and, to put themselves at risk of infection in that case as well. But one of the main things that I've really seen over the last 10 years or so has been this shift towards creating a healing environment within the hospital. And so if I think back, to my days in the United Kingdom, but also when I nursed in Germany, nursed in Frankfurt, and also from some of the Nordic countries, you still have a very clinical look and feel to hospitals, particularly the rooms as well. But here you can see other approaches, and these ones have really, been driven very much out of the United States here. You would expect some of this, especially for children's services. So this is the Florida Hospital for Children. You can see the different uses of color. You can see the uses of projected images onto the walls. The look and feel is very, very nice. It's very, not very clinical. The waiting areas are well designed. They're not formal or boring or cold or impersonal. And so this is a way that people have been trying to design these spaces to try and, remove the stress and tension that patients have, when they actually come into a hospital. And born from that is, the use of green spaces. Now, where possible, through atria and things like that, a lot of new hospital builds have incorporated, trees and plants and water features into those designs. But of course, that's not always possible, and it's not always possible if you're refurbishing a hospital. So here you can see some of the uses of mainly graphics that you can put up on the walls, on the ceilings that you see here, which just give a nice feeling to this. So this use of art, this use of lighting, creates a very nice environment, but also can help orientate visitors, patients, and even staff to where they are in the hospital. And that also is a very, very good thing. Also designs, things like the reduction in long corridors, with lots of staff walking up and down, specifically on a night, creates a lot of noise. So thinking about some of the workflows there. I mentioned the emergency department, or the accident emergency, as we call it in the UK. This is, the entry point for many patients within the hospital. Now, some of the designs that you see here obviously are coming from the United States, and they have a different model over there because basically hospitals are competing against each other. In the UK, we don't have that. We have one national health service. And apart from, a brief time, I remember in the mid-90s where we had the internal market, where there was a bit of competition between, hospitals. Basically, hospitals in the UK don't tend to compete against each other so much in trying to attract patients in, to attract the footfall. So there is kind of a slight different way or motive for doing this in the United States and also in other countries as well, such as Singapore. But I think we can still be inspired by some of the goals and aims of creating these spaces to, the way that we try and break down those very formal and very cold and impersonal waiting rooms, with the use of the furniture spread around, not in lines, to really try and reduce stress there. And also to look at, how we can maximize the use of space and the use of staff ratio. So one of the common ones is this ribbon design for A&E optimization. I'm sorry I don't have time today to really go into some of these in detail, but again, later on, if you want to speak to me about this, I'm going to give my contact details at the end. Alice mentioned already the healing environment. So actually looking at the bed space here, we're moving away from those sterile clinical looking rooms, the use of wood and natural lighting. But here you can see on the right-hand side from Farrer Park Hospital in Singapore, how a lot of those gas outlets for oxygen and equipment are now actually hidden behind, the bed head. Or down on the bottom of the slide here, you can see again those clinical outlets, which remind you that you're actually in hospital, can actually be, when not in use, hidden behind things like pictures. I've seen some pretty awful pictures, but I gather that you can actually choose the picture that you want to obscure the equipment with. And of course, use of light. So obviously, where you can use natural light, that is very beneficial. And there have been, again, many studies that have been done that have shown that hospital rooms which have access to light, especially in the morning, actually have a reduced number of days actually spent in the hospital for those patients. So they've been able to reduce the length of stay. But of course, that's not always possible. And so the use of this circadian lighting, especially in units like intensive care units, which are 24-hour units, to try and reduce the impact of sleep deprivation, and ICU psychosis and delirium and things like that. So we can use lighting to try and orientate the patients to the correct time of day. Again, there's a load of studies and research that have been done on actually the effects of colors as well on therapeutic impacts, and being able to dim those at appropriate times, run various different light sequences, and to be able to do that while at the same time being able to provide the staff who are looking after the patients with some form of workplace lighting, which also doesn't affect the patient directly. Now, I just thought I would mention before I move on to the next topic, the considerations in designing post-pandemic, because I've seen a number of things which have come up in the press. On the right-hand side was a project that I dealt with, I think, about in 2012, which was a new build hospital in Chicago, Rush Medical Center. And you can see from the design of the building that it's, pretty, modern, futuristic looking. Actually, the design of the wards created a number of interesting challenges in terms of being able to observe the patients. But they actually had a lot of foresight when they built this hospital. And they were actually in a very, very good situation and position to respond to the pandemic, because they were able to scale the number of ICU or critical care beds and turn these into these infection control rooms using positive pressure, negative pressure, I should say, the negative pressure rooms. So they built in certain amount of scalability. So when there was overspill from the traditional critical care beds, they were able to meet that and still, protect staff and still, try and keep as much infection as low as possible, cross-infection with that. And they also built in other things like decontamination pop-ups in the ambulance bays as well. So there are a number of things which you can do to this Tang Tok Seng Hospital in Singapore. They also did exactly the same, but theirs wasn't through foresight like Rush had, because Singapore was directly impacted by the first SARS outbreak back in around about 2001, 2002. And they really learnt a lot of lessons in Singapore from that, and also built in that scalability. Also impacted at that time from the original SARS pandemic was Hong Kong. They were also at the epicenter, and so they actually built in purpose-built isolation intensive care units, which are only opened during times of flu epidemics, or now with this situation here. And they built into things basically a one-way workflow. So this is something that we're all kind of used to now. Here in the United States, when the pandemic hit here, one of the things that they introduced was one-way workflows within the supermarket. So, to minimize the risks, when you were shopping. But of course, this was born out of situations like you see here in Hong Kong, and the fact that they had this one-way workflow, how clean linen was brought in, how dirty linen was removed, and things like that. So lots of possibilities there.
Very good.
So just to quickly finish on a thing that I just wanted to talk about, which kind of links into all of this. And I see a lot of trends out there around the world. So looking at particular the big data. So a lot of hospitals are now starting to create these data lakes, where they are taking data from all the devices and all the systems and depositing it in these data lakes, which they are then, going back and taking the data from to use things like on analytics, to see how much, for example, anesthetic gas consumption that they're having, the number of alarms which are going off in a particular unit, but also those for research purposes as well, to do clinical studies. And so a lot of these things are being enabled by the Internet of Things, and in particular now the Internet of Medical Things. So devices that didn't, in the past normally have any degree of connectivity to a network are now becoming networkable. And so you're starting to see this and the collection of even more data. This can then be exported as well into electronic medical records, which are, particularly important in places like the United States, where there has already been that level of digitalization. But the one I just wanted to touch on was the top topic, which was interoperability. And this has become a very important topic over the last few years. But again, the pandemic has really heightened the awareness of interoperability because of this requirement for data sharing. So we have all this data that we're getting on patients, and what do we actually do with that data? And how do we share that data between different organizations, between different departments, and how can we optimize that? Because people believe that had we been able to detect those COVID-19 cases earlier, we could have actually helped mitigate the spread, through these topics on interoperability. So interoperability is basically this connectivity between systems and devices, creating new applications to access, exchange and integrate data in a coordinated manner. And so this is really to hopefully optimize the health of individuals and populations globally. And it's a very, very wide topic, and I can't cover it all today.
Can we move on, Richard?
Yes, certainly. Okay. So we can do that. And this is what we're trying to avoid, is this haphazard amount of equipment that you see piled up everywhere. This one is an example that I saw in New Zealand. And by connecting these systems and devices together, we can create different concepts which can also help the patient outcome and the healing environment. So one thing that we've seen from the pandemic is, remote control of devices, rather than going into a patient vicinity, being able to manipulate that device externally. And this started off with the Ebola, or driven out of the Ebola epidemic that happened a few years ago, but has now really taken, even more momentum because of the situation we've had here. Now, I've mentioned the healing environment in terms of how it looks, but if you have the most beautiful hospital room in the world, but you're being kept awake at night because of all the noise, then that is not conducive to a healing environment. So using this connectivity, using this interoperability, people have been able to connect, devices which are alarming, and put this all together, and to automate therapy, and to connect all this together is a part of data management. Thank you. Sorry, I had to accelerate at the end.
We're very grateful, Richard. It's a wonderful talk. I was fascinated with your talking about how we make the environment more informal, how we use light and color. And it's also very interesting how the pandemic, curiously, has accelerated a lot of innovation. And there are so many things around. So, everybody, we've heard about infrastructure from Alice. We've heard about innovation from Richard. We now turn to Johannes Brundin for sustainability. He's project manager at the Nordic Centre for Sustainable Healthcare. He comes from Malmö University. He's a Swede, and very intelligent, well-thinking man, and I'm very much looking forward to his talk. Johannes.
Yeah, thank you, Michael, for the introduction, and thank you, Barry, for inviting us to take part in this discussion. Yeah, my name is Johannes Brundin, and I'm working for the TEAM Foundation. We are located in southern Sweden. We are an NGO. We're helping organizations, private and public, with their sustainability strategies, environmental legislation, and ISO 14001, and so on. And we have one niche, which is sustainable healthcare. We have seen an increasing interest in this field, so we started Nordic Center for Sustainable Healthcare in 2015. And this, I was asked to talk a little bit about sustainability, and we're working with sustainable healthcare. So this is our take on the topic, and also talk about why we should work with it, and also the opportunities that we see. You probably seen this report from Healthcare Without Harm and ARUP. They concluded that 4.4 of all emissions globally comes from healthcare, which is, in comparison, it would be the 5th biggest country in the world. So it has a very big impact globally. And we're talking a lot about our travel habits with by flight, and in comparison, that is 3.4 of the total greenhouse gases within EU. So we're talking a lot about flying, but not so much about staying healthy and avoiding getting sick, which is much worse for the environment. And 4.4 is globally, and for UK it's 5.4%. Another way of looking at it is that healthcare puts stress on the environment, and a stressed environment will cause illness, and ill people need healthcare. So this will be a negative spiral. So, of course, it's the best way is to prevent people of getting sick, but when they get sick, they should get the best care possible, but in a sustainable way. And in third option is to look at the environment and work with the environment, not causing illness, but that is very expensive. So how do we work with sustainable healthcare? And we have done this figure to show that you cannot work just within, for example, public healthcare or within the companies or the state. It has to be all these stakeholders involved. So we need private and public healthcare, universities, companies, the state, NGOs, and development and aid. And we also need to put sustainable healthcare as a neutral platform in the middle where everyone can meet. Because if you put it within the public healthcare sector, it will be hard for the companies to collaborate. If you put it within the university, everything will be about research and so on. So we need the public and private healthcare to create the demand. We need the universities to do the research, companies to provide innovations, the state to set up the legislation, and NGO to pinpoint different topics, and also the development side. If we look at sustainable healthcare as an industry, it's also going on a horizontal level, not the vertical traditional silos that we have divided industries in before. We have, for example, construction. It's not all when we construct hospitals. It's only when we make sustainable hospitals. For example, life science and medtech. It's only life science and medtech with good environmental performance. It's clean tech with applications for healthcare, and regular companies, like if you're making pencils and so on, it's also in furniture that is also when it's applied in a context of sustainable healthcare. As an example, we can take if we have an MRI scanner producing waste heat in one end of the hospital. We usually just let the heat out, but maybe in another area of the hospital, we need hot water and heating. So if we can transport the heat from one side of the hospital to another through a ventilation system for a clean tech solution, then we can take care of it. So and that demands also an ICT solution to monitor the systems, and through that you can also collect data, which is good for you can use it for management decisions and understand how the building is performing and so on. So you need to connect all these silos to look at it from a system solution or a holistic perspective to get the best impact. And sustainable healthcare is also the concept has not. It's a new concept, we can say. So there is no coordination in this field. So that's what we try to do here, to connect the research, innovation, home market, and internationalization. You need the research at universities, innovative companies. You need the hospitals to create the demand, to create the good home market for the companies, and then spread the knowledge and the technology to the rest of the world. And when you create export for companies, you will also create new jobs in the region, and you will also create new tax revenues that goes back to the hospitals. So you can, in this way, create a positive spiral as well. And we, as we heard in the earlier presentations, we have also seen a new paradigm shift within during the pandemic. We are looking. We see that hospitals are looking more into resilient and sustainable healthcare. We cannot buy all the equipment from China. We maybe need also have like single-use items, masks and so on. Maybe we also need a local laundry that we can reuse fabrics and so on. So this do also create new opportunities for the local companies and also the development of the hospital. And what lessons can we learn from the Nordics? So we managed to. This is from the Nordic Council of Ministers. All the Nordic countries have a council, and for the healthcare sector, we managed to get sustainable and innovative hospitals as one of the 4 strongholds. So this shows that the political will and care from the political side that this is something that we should work with, or where we should be the best. And another thing is hospitals at the forefront. This is near Karolinska in Stockholm, but we can say that the public procurement is a strong tool. Also innovation procurement. It's also established in the management. So decisions are based on also like sustainability. It's also established within the organization. So we have environmental coordinators working on within the organization, looking at opportunities to improve, and also systems for environmental performance, environmental management systems, collecting statistics and on almost everything. Test beds is also a good example where new technologies are allowed to be tested to find new innovative areas. Also, there are environmental reports, or the environmental performance is represented in reports. And then we're also looking at system solutions. So the hospital is not a standalone unit within the city. It's a part of the city. So, and it's quite a big part. It's maybe 12% of GDP in Sweden is healthcare. So it's a pretty big part of the community, so to speak. And by setting demands or creating the demand of maybe district heating and district cooling, that can also be then provided to the rest of the city and create a sustainable city. National recycling programs, regional biogas digestion, wastewater treatment, clean energy, clean water, and clean transportation is all that can come to benefit for the population. So how do we see on international collaboration and spreading of knowledge or sharing knowledge and experiences, best practices? So yeah, during the pandemic, we had to think how to get the information out to within our network. So instead of doing study visits that we have done before, we created a report series where we are looking into different topics. So nitrous oxide destruction, lighting, geothermal energy, and ventilation are 4 that we have done last year. And we're also having a webinar when we released the report, and you can see the best practices from Swedish hospitals and also the available technologies that are available today. And another thing that we have a release very soon, it's Grönköping University Hospital. It's a virtual hospital, and we are collecting all the available solutions that are out there today, together with best practices from that are also installed at hospitals today. So you can go in here, look at different topics, and find solutions that are installed, and a little bit about how the technology works. So that's also a source of information which is accessible during the pandemic. And we also, when it's possible to meet, we set up conferences. These are from Montreal in Canada. There was 150 people from about 100 different hospital or healthcare institutions come to this seminar. We have done seminars with Yale, and we have been to Israel and many other places as well to collaborate on this topic. And this is our network. We have about 100 organizations. It's now an international network where we have hospitals, companies, and NGOs, and even governmental organizations. So that was a quick run through from our view of sustainable healthcare. And
Many thanks.